Rebecca Gonzalez, National Association of Social Workers, California chapter. We all know that the cut to adult dental was one of the most difficult cuts the legislature had to make, and we just wanted to add our voice that we support full restoration, and once the May revise comes out, for the committee to look at that. Thank you.
Thank you very much. Yes, we're all very grateful that this program is back. Thank you for your work on it, too. If there are no objections, this item will remain open. All right, next item, pregnancy-only proposal.
Sure. So as well laid out in the agenda, the proposal has two components. First, it establishes new income standard for qualified low-income women under Medi-Cal, which provides full-scope, no-cost Medi-Cal services for those with income at or below 109% of the federal poverty level. The second component is that it creates an affordability and benefit program for pregnant women with incomes above 109% and up to 208% of the federal poverty level who enroll in a qualified health plan through Covered California. These are women who would otherwise be eligible only for limited scope Medi-Cal. Under this part of the program, DHCS would cover the out-of-pocket expenditures of pregnant women enrolled in a qualified health plan. The out-of-pocket expenditures would include things like the premium amounts after the premium tax credits are applied, applicable cost sharing, co-payments, or any other covered costs that are required during their pregnancy and postpartum coverage. For services not covered by the qualified health plan that are Medi-Cal covered benefits, the women would be accessing those medically necessary pregnancy-related services outside of the qualified health plan through the Medi-Cal fee-for-service program. A couple of really key examples are dental services and specialty mental health services. This affordability and benefit program would be made available at the later of either January 1st, 2015, or when we determine that CalHERS is ready to actually operationalize this program. The budget assumes general fund savings of $17 million in the budget year related to the pregnancy wrap, and those savings represent the cost difference in Medi-Cal of providing the wrap versus the limited scope Medi-Cal coverage. There were several questions in the agenda. The first was to provide an update on our analysis of how Medi-Cal managed care plans provide CPSP services. We are continuing to analyze that issue, but just to be clear, Medi-Cal managed care plans have a contractual requirement to provide these services. They can provide them either through the CPSP providers or through any other providers as long as those services are being covered. In addition, some women in managed care plans seek and receive CPSP services directly through the Medi-Cal fee-for-service program. The next question related to an update on our analysis of whether the qualified health plans in Covered California cover the CPSP services. That analysis is still underway. We've reached out to the qualified health plans, and we are also reviewing their evidence of coverage to determine to the degree what these services would be covered. As noted in the agenda, we have heard from at least one plan that says they do cover all of these services.
Have you given a deadline for the updating of that information?
We've requested information by next week as a starting point with some of the key QHPs so we can start to understand that. The evidence of coverage that we're reviewing sometimes doesn't go into sufficient detail because the CPSP services are very granular in some places. So yes, we're hoping to get some information by the end of next week. And then we were also asked to discuss the differences in the benefits and costs between full scope and limited scope pregnancy-only coverage. The covered services under the Medi-Cal state plan are available to pregnant women based on medical necessity and are provided for women in pregnancy-only coverage when it's related to their pregnancy or could cause complications to their pregnancy. So there isn't a set of benefits that are just limited scope benefits in the pregnancy-only coverage. It's really if the women need those services because they're medically necessary and related to their pregnancy or would cause complications for their pregnancy. And finally, as we've looked at the fee-for-service costs for pregnant women in full scope coverage versus limited scope coverage, we generally see that the costs are equivalent in those instances, and that's the difference between the costs and why we did not score a cost in the expansion of the full scope coverage.
Did you speak to the question about how you propose to inform Medi-Cal eligible pregnant women of their right to receive services?
Yes. So we're going to accomplish this in several ways. So we are going to be doing this at the time of application by providing information in both the paper application and through the online enrollment site. We're going to be developing FAQs that we will be giving to providers, consumer advocates, and enrollment counselors so that they can answer questions about this. We will also be incorporating information into our welcome packets for new enrollees, as well as sending out, as I mentioned, related to the dental, the quarterly beneficiary notices. We're going to include information in that for existing enrollees. And in general, we would be putting information on our website about this where people can find out about how to apply for Medi-Cal and what the benefits are. We also do, believe the key to success here in our outreach and messaging is really to work with the consumer advocates, the provider associations, the legislature, and our colleagues at the Department of Public Health to make sure that the messages are getting out. I know there was also a question about how we would be informing the eligible women of their right to receive services that are not through the qualified health plan. We would again be providing that information in the welcome packet once eligibility for Medi-Cal is determined. We're also going to be working closely with Covered California in terms of ensuring that the plans and their call centers are informed of these services and how women can access them. And again, we'd be looking to work with stakeholders for other ideas on how to make sure that this information is made available, whether that's through special notification or other options that people may have. And then finally, the last question in the agenda regarding coordination of services. While it is generally a plan's responsibility to coordinate care, regardless of whether it's a QHP or a Medi-Cal managed care plan, we are going to work closely with Covered California and the qualified health plans in terms of how this policy would be implemented. And as we've already stated, for purposes of accessing these services, they would be doing that through the fee-for-service program.
All right, thank you very much. Legislative analyst.
Thank you, Madam Chair. In general, we think this proposal has merit for a couple of reasons. First, the proposal to shift pregnant women onto Covered California and provide wraparound services has the potential to both reduce general fund costs as well as potentially provide more comprehensive benefits than the pregnancy-only coverage that they currently receive. Also, with respect to the proposal to provide full scope coverage to women below 109% of federal poverty level, that would eliminate some coverage inconsistencies for pregnant women where some women are able to access full scope benefits and other women are currently only able to access pregnancy-only coverage. We do want to raise a couple of issues about the proposal. First, the issue of a fiscal issue. The administration assumes that there is no cost difference between providing full scope coverage and pregnancy-only coverage. As Ms. Cantwell mentioned, they recently provided some information to us about their analysis that they used to determine that. We're still looking into it, but we did want to flag it as a potential cost that is not built in to the budget. And there are also just some uncertainties about how exactly certain aspects of this proposal will be implemented. Ms. Cantwell referenced the CPSP services and the degree to which different plans cover those services. So I believe some of those issues still need to be resolved. And so for that reason, we think it makes sense to hold this item open as some of these things are discussed further.
All right, thank you very much. Department of Finance. I do have some questions that I can't fully articulate, except for the fact that I am concerned about, how one determines their coverage based on whether they are pregnant, they become pregnant later, that's a short period of time, and how this will all work. And I'm sure we'll have some people who can articulate that a little better than I can. But just, it's very confusing. And I can only imagine a person who is seeking health care that it might be a little confusing for them too, what category they belong in and whether there's really equity in the services based on whether you're pregnant or not. So.
Sure. I mean, this would go back to some of what I was saying earlier about trying to create the most streamlined approach, both the covered through our online CalHERE's Covered California application, as well as how to create standardized benefit packages. So from a women's perspective, in many cases now with the individual mandate, they're coming on to coverage. They'll be coming on through Covered California, and they will be coming on before they're pregnant. And what would happen under this proposal is they would be, let's say they were above 138% of the federal poverty level. So they were on Covered California Qualified Health Plan, and they become pregnant. Then at that point, they could stay with their plan, but they would also be eligible for Medi-Cal, and it would mean at that point that they would have no cost sharing. It would take their cost sharing down. So the same provider, same delivery system, and they would be able to then have a reduction in cost sharing. They wouldn't be forced to, either to stay in qualified health plan, have the same cost sharing requirements, or leave and go to Medi-Cal and change the provider directly. They could stay in the same place. So that is the way to make it. Think of the other approach issue is let's say they were uninsured and they were pregnant women. They would come on, they would go through the online application, and they would be given these options. They'd be given the option of they could go into a qualified health plan, and as I said, have no cost sharing, by also having Medi-Cal. Or they would be given the option that they could say, no, I just want to go on to Medi-Cal and choose my doctor, and they could be on Medi-Cal, but they would have the pregnancy only. They would have a benefit package that have certain requirements. So they would have to have these choices, and we're going to work on informing them of those different choices. But the point here is we're trying to create a consumer-friendly process within the context of the individual mandate in the future. Our goal, everyone's goal, is that the majority will have coverage, and then it gets to a point of how do we make it as affordable as possible and create continuity of care as well as high-quality access to pregnancy services.
Yes, and I can see that the goal is to provide a good level of coverage, a high level of coverage, and that there are some benefits to this. I'm having a hard time understanding how this will work in a practical sense as you're dealing with a time frame, so.
Well, I mean, we as Ms. Cantwell laid out, the earliest would be 2015 that we would implement it January, or we are making lots of changes in the system. But I can continue to commit. I mean, from our perspective, this is about providing more affordable and more expansive care to pregnant women. But yes, we're going to have to look at how do we operationalize that. Right. That's why we put the statute in that it wouldn't happen for sure on January 1st, but when we're all ready, and make sure that we both are doing the right informing, making it as clear as possible, because you're right, any change is confusing, that we're not disrupting care, and that we have all the infrastructure in place, and we can commit to that.
Yes, thank you very much. Senator Riding, any comments, questions before we move along? Public comments, please.
Good morning, Jennifer Kent with the Local Health Plans of California. 14 of the state's Medi-Cal publicly sponsored not-for-profit health plans. We absolutely support the concept and obviously are interested in providing services to these women, and we understand the state's interest in trying to maximize the use of federal funding on the Covered California side. I think our concerns are mostly around the technical aspects, which you have alluded to and they've all said are complicated. So to the extent that this is an item that's being held open today, that's something that we would be interested in working with the administration on, because obviously we have concerns if women are in Medi-Cal or the exchange and it's not a plan that's in the Medi-Cal program, how are you actually kind of just making sure the benefits in the various plans are talking to each other, or whether they're even in a plan at all. And so that's just something that we would want to be continuing to work with the department on. Thank you.
Thank you very much.
Good morning, Lynn Kersey again, Maternal and Child Health Access, and we very much appreciate and support the increase to 109% proposed for full scope Medi-Cal for pregnant women, but then why not take it to 138 and then 200 to completely eliminate all these different silos and align the programs accordingly. We think the 200% program should be all services necessary. We are very concerned about the wraparound proposal, the premium assistance proposal, for three main reasons. One is that the Medi-Cal population is a high-risk population by its nature. Poverty is a high-risk condition. And the State OB pilot project showed that these services, these enhanced non-medical services in CPSP, significantly improve birth outcomes and save money. And all pregnant women in Medi-Cal have a right and a need to access to CPSP. It's part of the Medi-Cal benefits package. It's required by state statutes and regulations, and federal premium assistance regulations entitle beneficiaries to all the state plan benefits. The problem is that when the women's Medi-Cal provider is not networked with their Covered California plan, as was stated, women will not be able to access these services. The analysis gave one example of one Covered California plan, and we would need details to see whether those benefits, which are probably ACA-required preventive benefits, are the same as CPSP. We don't know. But ACA's preventive services are not CPSP. Covered California plans are not required to provide CPSP, and it's a proven program. There are options for the department. They can require or incentivize Covered California plans to network with Medi-Cal. Women in Covered California plans that don't include Medi-Cal CPSP providers should be allowed to go out of network for their pregnancy coverage, because you can't separate the pregnancy services from the enhanced psychosocial, nutrition, and mental health benefits that CPSP provides. The state can collect from the Covered California plans behind the scenes, and we look forward to continuing to work with the department on this issue, and glad that it's being held open. Thank you.
Thank you very much.
Good morning. My name is Karen Farley. I'm with the California WIC Association, and we do support the inclusion of up to 200% federal poverty level for women in full-scope pregnancy. But I wanted to mention something else, a full-scope Medi-Cal, but I wanted to mention something else that we are concerned about, and that is a lot of WIC participants do receive their medical care through the CPSP programs and greatly benefit from those enhanced nutrition, education, health education, psychosocial, and breastfeeding benefits. And we've tried to find the evidence of coverage of many of the Covered California plans, and those we found do not detail the benefits that the CPSP plan provides. And just to give you a couple examples, in CPSP, a mother who might need breastfeeding support would see somebody trained in breastfeeding, a lactation consultant, and work through her plan. Similarly, a mother needing nutrition support would see a registered dietitian, and we do not see evidence of coverage in the Covered California plans for that. We don't also see the details that a mother would be provided a pump that would help initiate and maintain breastfeeding and then provide it in a timely manner. And those are concerns if we want to have good health outcomes for breastfeeding. So we would ask that that be looked at very carefully so that the high-level CPSP benefits are maintained for the Covered California plans and not be, at this point, looked at as equal. Thank you.
Thank you.
Good morning. I'm Dipti Singh with the National Health Law Program. We strongly support the proposal to provide full-scope Medi-Cal coverage to pregnant women with incomes up to 109% of the federal poverty level. However, we strongly urge you to provide pregnant women up to 213% full-scope and similarly comprehensive coverage. Second, we support the comments made by Maternal and Child Health Access regarding the CPSP program. Pregnant beneficiaries enrolled in a qualified health plan must have access to CPSP to the same extent as if they were enrolled only in Medi-Cal. Thank you for your time today.
Thank you very much.
So I assume with Health Access, we do support a bright line at 138% federal poverty level and look forward to working with the committee on this issue as it moves forward.
Thank you very much.
Hello again, Shannon Smith-Crowley, American Congress of Obstetricians Gynecologists for California. I just want to say one thing I haven't really heard from others is that my understanding was what under the Affordable Care Act was that the state was supposed to move all pregnancy-only coverage to full scope unless they get permission from the federal government. So I haven't heard anything about where that stands and that there should be a contingency if you decide to move forward with the pregnancy only, but what happens if the state doesn't get permission to do that? But one of the concepts of the whole ACA is that we're supposed to be providing consistent comprehensive care and be moving away from body part programs. And as many people think, a pregnant woman is essentially her belly. It's much more than that. In fact, one of the leading causes of maternal death is heart disease. And in these women, a lot of times you can't tell. If it's an urgent situation, of course you can get emergency care. But what if it's a heart murmur? The OBGYN can't get a referral to a cardiologist unless it's a critical condition. So, you know, the other thing is about the pregnancy or the wrap. In concept, great idea. We really don't want people moving in and out of programs. There's different providers in Medi-Cal and in the insurance programs. But the CPSP component is absolutely critical, and in the physicians that work with these populations and have the CPSP services in their office, they say it's completely distinct services that they provide for the Medi-Cal population They're similar but very targeted to this population, not unlike how there's very similar but targeted programs for the Black Infant Health Program. There's certain risk factors and certain things that are covered in these programs that aren't in the just generic preventive services. And in fact, just yesterday, I got to attend a really inspiring awards program. The March of Dimes had on their an award to Dr. Ron Chapman for reducing his part in reducing the state's prematurity rate down to 9.6%. It had been increasing. And in fact, CPSP was one of the programs he cited as a key factor in reducing the prematurity rate. So ACOG would like for this committee to consider full scope for every pregnant woman, and when you look at the detail of the pregnancy wrap, to make sure, as everybody else has said, that you do include the CPSP components as well. So, thank you.
Before you leave, Ms. Fuller, could you please restate that question with regard to the federal question regarding, you stated, have we been given permission or not?
I can respond to it. As part of our program, we have to submit state plan amendments to effectuate how we deliver services and benefits. So we have a state plan laying out and specifying those benefits. We have many different state plan amendments, and we fully expect to get approval of that state plan amendment.
All right. Thank you very much. Thank you.
Good morning. Holly Lane Bean on behalf of March of Dimes and the California Nurse Midwives Association. Both groups believe that this proposal has merit, but would like to highlight a couple of concerns. March of Dimes would like to see the full scope Medi-Cal provision expanded up to 138% of the federal poverty level, so that these women are treated no differently than their non-pregnant counterparts. Additionally, we would like to ensure that these women have access to CPSP services, and that these women are allowed to have the choice between Medi-Cal or the exchange and are educated on their options so that they can make the choice that's best for themselves. The California Nurse Midwives Association would like to ensure that women in the RAP have access to certified nurse midwives, which is a federally mandated benefit, and also continue to have access to CPSP. Thank you. We look forward to continuing working with you on this.
Thank you very much.
Vanessa Kahina with the Western Center on Law and Poverty. There is certainly merit to this proposal, and as we always have, we have supported that women who are pregnant should not be treated differently from somebody who is not pregnant when they're attempting to enroll in the Medi-Cal program. As such, we would certainly support expansion of full-scope Medi-Cal services to these women up to 138%, and then perhaps the option that for a woman up to 200, whatever the MAJA equivalent is, that she have the option of either choosing between the full-scope Medi-Cal or covered California with the RAP. We have many of the same concerns as other advocates regarding the CPSP program and the incorporation into the RAP with those benefits and the interaction between covered California plans and Medi-Cal managed care plans. There are several other concerns outlined in our letter regarding repayments of possible tax credits that we find to be somewhat cumbersome and punitive, but we do appreciate the movement on this proposal and we'll continue to work on this. Thank you.
Thank you very much.
Hi, Beth Lanowski again, the California Primary Care Association. Really just want to second the comments and concerns made by our peers. We're excited to see a proposal that extends full scope Medi-Cal to 19%. Love to see it go further, at least to 138%. We similarly have concerns regarding the ability of women to really access these critically important CPSP services and making sure they can access those providers that have been committed to that program for so long. Like you and the LEO, we do want to see a lot more information regarding how this will play out in a practical sense. We're concerned with the implementation for those components that even look good on paper right now. What will it look like? How will a consumer truly know the differences between plans, what those benefits look like, their access to providers? Similarly, making sure that these consumers have choice in the process, know what their rights are, and can really maintain provider relationships that they've developed through other pregnancies and other care they've received. So we look forward to working with folks on that, but would like to see a lot more detail there. Thank you.
Thank you very much. All right. I believe that item will stay open.
Just wanted to say one thing.
Yes.
We're looking forward to continue to work with stakeholders on this, and one thing that we will be coming forward and bringing to your staff as well as stakeholders is we're finishing up an analysis on looking at our both CPSP as well as those in private insurance and how that compares in terms of birth outcomes, C-section rates, looking at it to see the value and how it's providing high-quality services. And so we'll be presenting it to give a full picture.
Thank you very much. We'll appreciate that information. Thank you so much. The next item is the county realignment and request for positions.
Sure. So briefly on the request for positions, we are requesting 18 positions to implement the various provisions of AB 85, which includes the calculation of the savings, the various reconciliations that are required, rate development, some policy development, and the appeals processes that are available for counties. So that's the sort of overview of the proposal really quickly. You had a couple of questions in here sort of related to AB 85 more generally. The first question being about what county programs are funded with health realignment and any reporting requirements to the state. So as part of AB 85, for those counties that chose the formula option, we did have to collect various information on how they were spending their health realignment funds. Generally, what we saw and we were able to identify is it's sort of in three categories: indigent healthcare services, public health services, and jail health services. And as part of that information that we collected, we were able to find out what services were being covered both in the indigent side as well as what public health services were being funded with health realignment. So for those counties, again, that elected the formula, we did end up being able to determine how much of health realignment was used for indigent health care. There are no specific requirements in AB 85 for counties to report to the state how they will use this funding in the future, or if they are going to propose changes to their services. However, again, for those counties who are subject to the formula, we will every year be collecting data on the cost of the services that they're providing for indigent health, as well as the numbers of people being served. So that information will be available. And then in general, in terms of an update on the implementation of AB 85 and our ongoing work to update the estimate for 14-15, as the agenda lays out, AB 85 was clearly a key component in the ACA implementation, and it contained really two key elements. The first being two options for counties to choose related to the determination of the amount of health realignment that might be redirected for social services programs due to the savings that we expect to see in indigent healthcare services because of the Medi-Cal expansion. And the second component was requirements related to primary care provider assignment and reimbursement levels for county public hospital systems, who are some of our core safety net providers. So the department, in coordination with our Department of Finance colleagues, the counties, and the health plans, have been working to implement both components of AB 85. With respect to the county options for choosing the realignment redirection, in the end, all 12 public hospital counties chose the formula option, and so did 7 of the non-public hospital, non-CMSP counties, meaning that 5 non-public hospital counties and all 34 CMSP counties are just going with a straight 60% redirection. For those 19 formula counties, we've worked with them over the past several months to determine the required historical determinations, sort of what I was mentioning earlier about realignment and some of the other spending that they did in the historical period. So we issued those at the end of January, and counties had until February 28th to appeal those determinations. Initially, 8 counties appealed the determinations. 4 have since either officially withdrawn or have indicated they will withdraw. We do anticipate the remaining 4 will continue through the appeal process. And I forget the actual name for it, the county health committee that consists of the Department of Healthcare Services, Department of Finance, and a representative from CSAC will hear those appeals and issue decisions by mid-April. And then finally, as for the development of the 14-15 savings estimate, we are currently working on building assumptions based on the information we collected in the historical determination data. We'll be using that data for the historical years and then coming up with what factors we might think are appropriate for figuring out how much savings is the county going to actually experience in 14-15. We will be working on those collaboratively, both with the Department of Finance and with the counties, on what assumptions we can make based on sort of what are they experiencing already in this year and what we think might happen in the future. So we will have an updated estimate for the May revision.
Okay, thank you very much. Legislative Analyst, Department of Finance. All right, comments, members? All right, public comments on this item? Good morning, still, just barely.
That was quick. So White Seam with Health Access. Just wanted to mention that we recently released a baseline report looking at indigent care services provided at the county level. We look forward to hearing more on this issue so we can better understand the issues around capacity and county's ability to provide indigent care services. Thank you.
Thank you very much. All right, without objection, this will remain open as well. The next item is Medi-Cal eligibility under the ACA and request for positions.
I'll be brief on this. As I discussed earlier, there are a lot of changes in the eligibility rules as well as how that impacts our IT systems. And we're doing a lot of development both in terms of guidance and continuing to provide guidance out weekly on the changes and working with our stakeholders and county partners and Covered California on how the new rules will be effectuated. In addition, there are IT systems with our med system, as well as with the SAS and CalHERS, all that have to be in sync. There is a question here about why we need this work's just going to, we're doing the work now. And we'd be happy to sit down with your staff as well as the LEO to go into more detail. But the short answer is this work, while we're getting out guidance here, this is in many cases guidance that's in the form of letters that is not the full force of law. We have to work on regulatory packets, on all county welfare director letters. We also have a lot of work on just stepping back and looking at all the previous all county welfare directors letters and making sure that they're in sync, because all of the rules have changed, and the staff will be doing this beyond the current year into the future. The same on the IT systems. The rules are going to continue to change. There's work that we'll have to do to continue to stay in sync with SAS and CalHERS as we provide future guidance.
LAO have comments on this?
Thank you. With respect to the 4 positions in the Medi-Cal eligibility division, based on the implementation timelines provided in the proposal, it appeared that many of those activities, or all of the activities, were supposed to be complete by June 2015. The proposal requests positions to be extended through June 2016, and so we were just looking for clarification on exactly what those positions would be doing, what activity would be done after June 2015, and we're happy to work with the department to get a little bit more detail on what will be done during that period.
Thank you. Department of Finance, public comment, you want to come forward?
Thank you, Vanessa Kahina with the Western Center on Law and Poverty. Primarily, it's important to sort of take a look at the entire universe and how many changes are happening right now. We are thrilled that the department has taken up options to transition in a kind of just press play method the low-income health program enrollees as well as people on food stamps. So at this point, we've transitioned about 650,000 LAHP members into Medi-Cal through express lane enrollment. These are huge successes, and we should certainly be proud of ourselves as a state as leading the nation in the implementation for the lowest income Californians of the Affordable Care Act. We do have to take this opportunity, though, to say that there are very serious eligibility errors getting in the way of people getting coverage and services that they need right now. Today, there are about 670,000 pending Medi-Cal cases because of a system problem or more information needed. We really applaud the administration's decision earlier this week, which we had pushed for, to allow self-attestation of state residency for pending cases as well as new applicants for this month and next. There isn't very much incentive for someone living in another state to attempt to get a Medi-Cal card, and the state has not made good on its promise of checking with state electronically. So in terms of being able to check the data hubs on where somebody lives, we're not there yet. So we're very happy to have the self-attestation option for the time being. It's something that we would like to see continue in perpetuity. But that change alone is estimated to clear at least half the cases, but it's still leaving about 335,000 Californians in Medi-Cal limbo for health coverage. And also have to add that there are extensive problems leading to those who already had Medi-Cal including people terminated who are eligible or giving them large shares of cost, both of which disenroll them from their Medi-Cal plan and interrupt their care. In the middle of this, the administration plans to start sending next month renewal forms for Medi-Cal, which are very confusing and we continue to work on with the department. The federal government has given other states flexibility to delay renewals, and we urge California to do the same to get the process right. We should be focusing on fixing the problem instead of sending faulty renewal notices for the time being. Thank you.